father actually had a disability. He had ankylosing spondylitis, and that was in the 40s and 50s, where they didn't have a lot of treatment options for that. So looking back on it, I think that was my first inspiration that people with disabilities needed a better way to move through medical care.
Once I decided, or discovered, I should say, physical medicine and rehab, which gave me functional neurology with non-operative musculoskeletal or orthopedic stuff with a little blend of function and always grounded by practicality, that sort of gumbo, to borrow a New Orleans reference, really appealed to me, and I knew that gumbo had to be spiced with children, because that's where I felt I could make the biggest difference.
When you look at how people function, that's really the biggest deal, is how do they get from point A to point B? How do they love, work, and play, which is really an important part, and try and keep that in balance? How do we get them in a peer population that they can actually see somebody who's been successful, so that they can actually say, I could do that?
It was in my third year of medical school that I had a diving accident with a C5 burst fracture and a resultant C6 spinal cord injury. And I'm sitting there thinking to myself, wow, what do I do now? How am I even going to finish medical school? What am I going to do? Obviously, I couldn't be an orthopedic surgeon. What field would fit that I could participate in and contribute? And I guess the answer was right there in front of me.
We're a patient-centric specialty. We're not just going to look at the x-ray and do an injection. And I think really putting the patient and their family first is really a unique characteristic of our specialty. And I think as medicine has evolved to be more customer service oriented, that we're actually one of the specialties that can role model that for other specialties, because that's who we are. We want to know the patient. We want to know what their values are, what their goals are, not just what we think we can do.
Our patients can teach us how to be better doctors, how to be better persons, how to be better practitioners of medicine.
I think that rehabilitation is also an educational intervention, and that we are teaching patients new skills, adaptive strategies, compensatory mechanisms. And at the end of the day, our primary outcomes are their performance.
I feel like a physiatrist is uniquely skilled to be able to identify their concerns, to understand how the disease or illness or the condition is going to impact the patient's life, be able to predict their needs, and then coach them through the process.
I think the team model and the understanding of how to work together with team members is also a core value for our field. I really think we have been as thoughtful as anyone. I
think a key core value is the understanding of the interaction of different systems and the fact that their interaction will alter the patient, as opposed to looking at the patient as just one system altered. And most of medicine, if not all of medicine except for what we do, is really focused on a system, an organ system.
I think that the beauty of our specialty is that we move beyond pathophysiology. We move beyond the biomedical model, and we take a much deeper look at the human being and how they're interfacing with their world, and also what they desire to do in their lives.
I started in a musculoskeletal heavy environment, and that's really what I did well. And I morphed into this more inpatient related kind of thing, but still to pay the bills. I did all the musculoskeletal kinds of things, and now am really more of a global viewer of disability and health.
It's one of the fascinating things about rehab medicine is that, you know, you can pick what you want to think you want to do going in the door in rehab medicine. Then you can get exposure to a lot of different things and be competent in a lot of different things coming out of residency. decide what you want to do, but then evolve.
I don't come in thinking this patient must be thinking this, or if someone has this condition, these are the concerns the patient's going to have. So I usually go in there and ask them what they want out of the visit, what they are concerned about. And I've been surprised at some of the concerns that the patients have had.
We see a need and we fill in the gaps, and then we innovate and we do research and we figure out how we can help, and then we make that a new area.
It was very eclectic and it was very functional. You just remember how they were trying to, it was all about kind of improving people's ability to function. I thought, that's pretty cool.
If you look across the specialty, just about everything we do, whether it's pain injections or whether it's rehabbing a spinal cord patient, it's really to restore quality to life. So I think it's really one of our core values that we should focus on as we're making decisions in the future, not only on a personal level, what do you do in your practice, but also what do we do as a specialty.
And no one else does that. No one else takes on, I'm here to manage the patient. And when you think about the embodiment of what it means to be a doctor, that's what it is.
When the students come through clinic, they often exclaim at the end of clinic, like, wow, I didn't know that PM&R was all of these things, and you have such a wide variety of patients, and you can help so many different kinds of patients. And and they see the common thread there that, of course, is through various different conditions.
I'm sure everyone you've talked to has said, I really love what I do. Most people, I would say 90% plus, have to say that, because we do. What we do is just an amazing thing in the medical world.
I love my job. I don't think anyone could have even fashioned this job for me 25 years ago any better than it has turned out.